Hello everyone, welcome to the session of Biochemistry Image-Based Questions. I am Dr. Rebecca James, your faculty with Marrow. So as far as biochemistry is concerned, the images are mainly coming from three areas. Number one is the common test in biochemistry. Number two is the metabolic and the nutritional disorders. And the third is the enzyme kinetics related graphs. So we will be covering the image-based discussion under these three headings. So first we are going to the common test in biochemistry. So the two major topics that comes under the common test is the test for carbohydrates, not all the tests very commonly done only, then the abnormal constituents of urine. So the first question is a 75-year-old diabetic case brought to casualty with altered sensorium and deep sighing respiration. The given tests were positive. What is your diagnosis? Okay. So when you see this history, you all know that the first diagnosis that should come to our mind is a case of diabetic ketoacidosis. In a case of diabetic ketoacidosis in urine, we know that the urine glucose will be positive. So urine Benedict's test is positive. So the first image that is given here is the Benedict's test. Okay. So in this particular image, all the positive reactions are given here: green, yellow to orange, and finally this is the brick red color. So this is a semi-quantitative test, very easy to identify. You all know this. So this is a Benedict's test positive. Next is a ring test. So what is this ring test called as? This ring test is called as, yes, you know that. Tell me. Yes, it is a Roth-Eras test. Okay. So how will you identify a Roth-Eras test? It's very easy. First thing is you can see a ring at the junction of two liquids, and you can see some ammonium sulfate crystals at the bottom. Okay, so this is how you can identify a Roth-Eras test, and Roth-Eras test is answered by whom? Roth-Eras test is answered by ketone bodies. Which all ketone bodies? One is acetoacetate and acetone. So these are the two ketone bodies that answer Roth-Eras test. But please mind that acetone will not answer Roth-Eras test in this case. Why? Because in a bedside test, when you are doing Roth-Eras test, acetone will not come into urine because acetone is excreted through lungs. But in the biochemistry lab, we usually get acetone and acetoacetate. Both of them will answer Roth-Eras test positive, but in a bedside test, this is answered only by acetoacetate, not by acetone. The simple reason for it is acetone is not excreted through urine. It is excreted through lungs. So that is why you will get a smell. What is that smell? Fruity smell. So fruity smell is because of the smell of acetone that is coming out, because acetone is excess and that is excreted through the lungs, not through the urine. Okay, so going to the next question, a 56-year-old man presented with jaundice. He also gives complaints of loss of appetite, tiredness and itching. The following urine tests done in clinical biochemistry lab were positive. So this is a filter paper test. What is this test? This is Fauchet's test. Fauchet's test is answered by whom? It is answered by bile pigment. What is a bile pigment? It is nothing but bilirubin. Okay. So if bilirubin, and this is a urine test, it is done in urine. So if bilirubin should come in urine, means that that type of bilirubin should be conjugated bilirubin. Conjugated bilirubin excess you can find in obstructive jaundice. Okay. Again, in this history, what you can see is itching. Itching is characteristic of obstructive jaundice. What is the reason for it? Because the bile salt excess in the blood, which can deposit in the skin, which can cause itching. Again, what is this test? This test is Hayes test. Hayes test is answered by whom? It is answered by bile salt. So, if bile salt or Hayes test is positive, it means that there is an obstruction to bile flow. So that whatever is in the bile, which includes the bile salt, is coming to the blood, and from the blood it is excreted through the renal circulation, it is excreted through urine. So, always remember, when these two tests are positive, it is obstructive jaundice. One more possibility is there, hepatic jaundice. This history is not so characteristic of hepatic jaundice. Apart from that, by doing these tests, hepatic jaundice, it is like plus or minus. It is biphasic. It is not always positive. So, from this test is positive, it can be obstructive jaundice or hepatic jaundice. In the case of hepatic jaundice, remember, it is not always by seeing or by doing these tests we can never confirm that it is hepatic jaundice, because we have to do other enzyme studies as well. So, as far as this case is concerned, it's a case of obstructive jaundice. Okay. Next is a test which very commonly done in biochemistry lab. So the next question is, a 5-year-old child with anasarca and with scrotal swelling. He had froth in urine for 3 days. Urine test done in the image was found to be positive. BP is 100/80 millimeter mercury. No history of hematuria. So what is this case? This is a case of nephrotic syndrome. In nephrotic syndrome, we know that there is albuminuria. Okay, so in other words, we can also write there is massive proteinuria. So how can we detect a urine protein? It is detected by a test? Yes, it is heat and acetic acid test. So this is heating the upper portion. You can get a cloudiness in the upper portion. And what you will add after this? You will add acetic acid drop by drop. Drop by drop. So, when you add acetic acid, if the cloudiness is increasing, then it is consistent with protein. Okay. Especially the most important protein that is coming in the urine is the albumin. Okay. So, this is called as heat and acetic acid test. This is a test for protein in urine. Okay. Next, we go to another question. In a patient whose urine was sent for microscopy, showed the following crystals. Later workup, it was found that a dibasic amino acid transporter is defective in kidney. So, what is this? So, what is this image? You can see hexagonal crystal, right? And if you see this image, you can see that it is flat topped hexagonal crystals. So, what is this? It is cystine crystals. Cystine crystals is giving this characteristic shape. Remember, what is this condition called as? This is called as cystinuria, where a dibasic amino acid transporter is defective. Apart from cystine, what all things are excreted in urine? That is COLA. C stands for cystine, O stands for ornithine, L stands for lysine, and A stands for arginine. Okay. So, this is a case of cystinuria. So, we'll go to the next question. A child accidentally ingested ethylene glycol. In his urine examination, the following crystals was found. The clue to identify the crystal is given here, and these are envelope shaped crystals. Envelope shaped crystals you can find in calcium oxalate stones. Fine. So, which are the conditions that you can get oxaluria or oxalate stones? Number one is ethylene glycol poisoning. Is there any vitamin deficiency that can cause the same? Yes, it is B6 deficiency. Okay. Then a vitamin excess can cause the same. What is it? It is vitamin C. Is there any anesthetic agent that can cause oxaluria? Yes. Methoxyflurane is an anesthetic agent that can cause oxaluria. So these are the conditions where you can get oxalate stones in urine. Next, we are moving on to metabolic disorders, where we have to cover all these topics one by one. So the first is a 10-year-old tall-statured boy presented with the following findings. He had history of myocardial infarction 1 year back. So what all things you can find here? This is the sternum is pushed outwards, that is pectus carinatum. And you can see genu valgum. This is arachnodactyly. What is this? Dislocated lens. This is not in the same patient, but this can be seen in this condition. So this is just the reverse of it. This is pectus excavatum. And finally, what is given here is a test that is positive here, where you can get a magenta color as the positive reaction. What is this test? It is cyanide nitroprusside test. Okay, now this is enough. What is this case? This is a case of classic homocystinuria. What is the enzyme deficiency in classic homocystinuria? It is cystathionin beta synthase. This is the enzyme that is deficient. Okay, so this is classic homocystinuria. We will see the next slide. A 50-year-old female come to orthopedics OP with complaints of back pain. She also complains of dark spots in the eyes and dorsum of the hands. And this is another feature. You can see black colored urine. And the X-ray findings, number 1 is bamboo-like spine. This is bamboo-like spine. Okay, now tell me what is this? This is a case of alkaptonuria. Very easy. What is the enzyme deficiency in alkaptonuria? Homogentisate oxidase. This is also homogentisate dioxygenase. Okay, so this is very classical. Everybody can identify this case. So this is a case of alkaptonuria. Fine. Next, what is your diagnosis? There is an ocular lesion, that's a corneal ulcer that poorly stains with fluorescein. And what you can see on the soles is non-pruritic hyperkeratotic plaques. So this can be seen on the palms as well. So what is this? This is oculocutaneous tyrosinemia, which is type 2 tyrosinemia. What is the other name of type 2 tyrosinemia? Richner-Hanhart syndrome. What is the enzyme deficiency? Type 2. What is it? Tyrosine transaminase. Okay. So that is about Richner-Hanhart or type 2 or oculocutaneous tyrosinemia. We will go to the next. A newborn has milky white skin, white hair, red appearing eye color. So what is this? So milky white and milky white skin always stands for depigmentation. Depigmentation. So what gives pigment to our skin? We know that it is melanin. So melanin is synthesized by which enzyme? Tyrosinase. So what is the condition that you can think here? It is a deficiency of tyrosinase, and that is albinism. Okay, it's very easy. Next, good looking, fair skinned child with blonde hair was brought to pediatric OPD. The parents complained of an unusual mousy body odor, very straightforward, developmental delay, agitated behavior. So, this is not depigmentation, but this is hypopigmentation. Hypopigmentation because of again decreased melanin synthesis. So, what is the defect here? This is because of phenylalanine hydroxylase deficiency. What's the function of phenylalanine? Phenylalanine converts, phenylalanine hydroxylase convert phenylalanine to tyrosine. So, if this is deficient, tyrosine is not synthesized, melanin synthesis is also reduced. So, that is why there is hypopigmentation. So, what is this condition called as? It is a case of classic phenylketonuria, and the classic odor that you can get is mousy body odor. Next question is, a 3-week-old neonate presented with hypotonia, poor sucking reflex, and intern examined the baby, collected some urine, keep it in refrigerator for one night. The next day, a sweet smell was appreciated in the urine sample. She did a DNPH test and it is found to be positive. So, what is the positive DNPH test for? This is a test for maple syrup urine disease. What is the color that you can get? Yellow color. Yellow color. Characteristically saying it is deepening of yellow color is what you can appreciate in a DNPH test. What is DNPH? Dinitrophenylhydrazine test. So, this is a case of, and this is like the hypotonia. The hypotonia in the child is what is shown here. So, this is case of maple syrup urine disease. And what is the enzyme deficiency in maple syrup urine disease? I'll write the short form. Tell me what is this? BCKD. What is BCKD? Branched chain keto acid dehydrogenase. 7-year-old male presented with developmental delay, neurological, cognitive and behavioral disturbance. He is always trapped to bed to prevent self-injury. Okay, any clue you get? One clue I will say, male. And if I say the next one, you can very well answer this question. It is self-mutilation. So, if you get these two keywords, what is the diagnosis? It's a case of Lesch-Nyhan syndrome, where you can see the child has compulsive self-mutilation. So, to prevent that, the child is always strapped to the bed, and you can see this is the self-bitten toes, you can see here self-bitten fingers, you can see self-bitten lips, you can see. So, this is a classical case of Lesch-Nyhan syndrome. Why I said male? Because it is an X-linked recessive disorder. And what is the enzyme deficiency here? Hypoxanthine, guanine, phosphoribosyl transferase, HGPRTase, right? Always learn the short form, that's always easy to remember. So, this is a case of Lesch-Nyhan syndrome. We'll go to the next question. A 45-year-old male presented with the pain and swelling in the right forefoot. It is very classical of one inflammatory arthritis. What inflammatory arthritis? Gouty arthritis. Okay. Now, this is also very characteristic. This is one of the diagnostic feature of this condition, that is negatively birefringent monosodium urate crystals. This you can see in the synovial fluid. So, this is gout. It's a case of acute gout. And what is seen here, it's not a feature of acute gout. This is actually a feature of chronic gout, where you can see some swelling in the subcutaneous tissue. We can see what is that? It is tophi, where monosodium crystals, urate crystals accumulates in the subcutaneous tissue, which cause nodular appearance, and that is tophi, which is not a feature of acute gout, but it's a feature of chronic gout. A 6-year-old mentally retarded girl with protuberant abdomen umbilical hernia, short stature, coarse facial features with depressed nasal bridge, frontal bossing and steamy corneas, clawing of the hand. So what is it? This is a classical case of mucopolysaccharidosis, MPS 1H. What is MPS 1H? Hurler disease. What is the enzyme deficiency? Alpha L iduronidase. And these facies are called as gargiolic facies. Okay, it's very easy. You can very well diagnose from the history itself. This is mucopolysaccharidosis 1. So this is again the same thing. I just show two more additional images that you can get there. This is a classical finding that you can find in the X-ray of the same thing, Hurler disease. Okay, so that is called dysostosis multiplex. Plus, what you can see here is the bullet-shaped middle phalanx. Again, it is an inclusion body that you can find in leukocyte, that is Rayleigh body inclusions, very classical of mucopolysaccharidosis. Again, this is a 16-year-old boy with short stature, coarse facial features, hirsutism. What is the characteristic here? This boy is not having mental retardation, but visceromegaly is there, clouding of cornea is there. So, no mental retardation. So, this is again mucopolysaccharidosis only, and this is MPS 1 only, but this is not MPS 1H, but this is MPS 1S. So, what is this? It's a case of Scheisse disease. Scheisse disease. And what is the enzyme deficiency in Scheisse disease? Alpha L iduronidase. Again, this enzyme is not completely deficient. If it's completely deficient, it is Hurler. So, this is only partially defective. Partially defective. That is the difference here. And if it is partially defective, these children are having normal intelligence. Okay. So, this is an 18-month-old boy. So, I will highlight boy here. Coarse facial features, hirsutism, mental retardation, clawing of hand, copious nasal discharge. And again, I'll highlight normal vision here. You all know what is this? Yes, hunters are males and males should have a clear vision. What is it? It is Hunter disease. Okay, Hunter disease is MPS 2. What is the enzyme defect here? Alpha L iduronate sulfatase. Iduronate sulfatase. Okay. This is a 5-year-old child presented with doll-like facies, or you can get another history like chubby cheeks, thin extremities, massive hepatomegaly, no splenomegaly, kidneys are enlarged, hypoglycemia, hyperuricemia, lactic acidosis. So, what is this? Von Gert's disease, which is type 1 glycogen storage disorder. What is the enzyme defect here? Glucose 6 phosphatase. One test will be positive here. So, which test is that? Rotheras test. Why? Rotheras test, because there is ketosis here. Okay, so Rotheras test also, that image can also be given along with this picture. So, this is a case of von Gert's disease. Okay, next, this is a boy presented with vomiting, jaundice, failure to thrive. So, I highlight the key feature here, breast feeding initiated. Hepatomegaly present, urine Benedict's test is positive. But at the same time, glucose oxidase test is negative, which means it's a reducing substance, but it is not glucose. Lactose-free diet initiated. So, that is all pointing towards classic galactosemia. Okay. Now, he has to use thick glasses. Why? Because this child is having cataract. What kind of cataract? Oil drop cataract. What is the enzyme deficiency? GALT. What is GALT? Galactose 1-phosphate uridyl transferase. So we'll see the next question. A 3-year-old child presented with abdominal distension, EC bruisability, bone pain. X-ray lower limb is shown here, is having this flask. What is this flask? It is Erlenmeyer flask. So X-ray of the lower limb is having this Erlenmeyer flask appearance. And what picture that is shown here is the crumbled tissue paper. What is this? Where do you find this? You find this in Gaucher disease. Yes. And what is this cell? Gaucher cell. What's the enzyme deficiency in Gaucher disease? It is beta glucosidase or beta glucocerebrosidase. Okay, this is a lysosomal storage disorder and this is also a sphingolipidosis. Okay, and this is the most common lysosomal storage disorder. Now we'll go to the next question. It's an 18-month-old child presented with painful joint swelling. It's a metabolic disorder associated with ceramidase defect, because just by seeing this image you won't be able to answer this. So some clue is given in the question also. So what is this? Ceramidase defect. Again it is a sphingolipidosis. Now if it's a ceramidase defect, I'll just give you one more clue. This is a disorder that resembles rheumatoid arthritis. Okay, tell me what is this? Yes, Farber's disease. Okay. Another question is a 6-year-old boy. Again, I'll highlight boy here. A characteristic feature in the skin, angiokeratoma. This is also very characteristic. It is a particular appearance in the urinary sediment, that is Maltese cross appearance, and lenticular opacities. Tell me what is this? It is a case of Fabry's disease. What's the enzyme defect in Fabry's disease? It is alpha galactosidase. Alpha galactosidase is the enzyme defect here. An infant presented with watery green diarrhea, relentless vomiting, failure to thrive, hepatosplenomegaly. The image that is given is pathognomonic of this. What is this? So what you can see here is calcification of adrenals. Okay. Calcification of adrenals, where do you find? It is found in Wolman's disease. What is the enzyme defect in Wolman's disease? Acid lipase. Okay. So this is a lysosomal storage disorder, but this is not a sphingolipidosis. Next is a 2-year-old child presented with recurrent episodes of abdominal pain. His blood was drawn for investigation. It looks milky white. And what you can see here is eruptive xanthoma, which you can find multiple numbers and it is discrete. One is separated from the other. Discrete, multiple numbers. And you can see this finding in the fundus, that is lipemia retinalis. Okay, so what is this? It's a case of type 1 hyperlipoproteinemia. Which is due to an enzyme deficiency. What is that? Lipoprotein lipase. Also an apolipoprotein deficiency, that is ApoC2 defect. And this is also called as familial chylomicronemia syndrome. And why this milky white color? It is because of accumulation of the lipoprotein chylomicron as well as VLDL, but this color is due to chylomicron. Next is a 20-year-old patient presented with chest pain, had following findings. What is your diagnosis? Again, you can see here is a xanthoma, but this is not multiple in number. It is solitary xanthoma. Solitary xanthoma that is usually seen on tendons. So what is that? It's a tendon xanthoma. Plus, another classical finding that you can see here is white ring around the cornea. That is corneal arcus. Tell me what is this? Again, one hyperlipoproteinemia. That's the clue that I am giving. Yes, it is type 2 hyperlipoproteinemia and it's otherwise called as familial hypercholesterolemia. Familial hypercholesterolemia. So, we will see the next question. A child presented with a swelling that resembles a bunch of grapes. Again, what you can see is yellowish discoloration on the palmar creases. What is that called as? It is palmar xanthoma. Okay, so these two findings you can find again in hyperlipoproteinemia. Which hyperlipoproteinemia? It is type 3. Type 3 hyperlipoproteinemia, otherwise familial beta lipoproteinemia. Okay, fine. So, we'll go to the next question. A patient presented with the following finding in the tonsil. By seeing the image itself, you understand what is this, right? It is a yellowish, orangish color in the tonsil. Okay, and reduction in HDL cholesterol. And I'll give you one more clue if you are not finding the answer to this. It is a defect in ABCA1 transporter. So, what is this? It is a case of Tangier's disease. So, orange colored tonsil, Tangier's disease. If this was a previous year question also. So, this is a defect in ABCA1 transporter. So, that HDL cholesterol formation is affected here. So, there is reduction in HDL cholesterol here. All other lipoproteins are normal. A child presented with the following findings to the OP are erythrocyte glutathione reductase. So, erythrocyte glutathione reductase, if it is there in the question, then the doubt that you should be having is a vitamin deficiency. Which vitamin? B2. Okay, so what all other findings is given in the picture? It is magenta colored or beefy red tongue. What you see here? Corneal vascularization. And what you see here? Chelosis, stomatitis, fissuring of the lips. All these things are characteristic of riboflavin or B2 deficiency. Okay. A patient whose staple diet is corn presented with erythema and rash in the sun exposed areas. So, what you can see here is the Cassell's necklace and lichenified indurated lesion on the dorsum of the hands. So, it is because of photosensitive dermatitis. So, you all know what is this. It is vitamin B3 deficiency or niacin deficiency. Always remember, corn or maize has B3 deficiency. Staple diet, corn or maize. Why? Because corn or maize have niacin in a bound form called niacin. One more reason is corn is deficient in tryptophan. So, what? From tryptophan, we should get niacin. Okay, so it's very easy. Another is a patient with hypertriglyceridemia treated with a vitamin. And after treatment, this is the picture. What is this? Flushing. Which vitamin excess can cause flushing? It is again vitamin B3, niacin. Excess cause prostaglandin mediated flushing. How can you treat it? Pre-treatment with aspirin or a PGD2 antagonist. It is called laropiprand. Okay, so that is excess of niacin can cause flushing, prostaglandin mediated flushing. Okay, we'll go to the next question. Very simple question. You all know it is the dryness in the eyes. You can see this is almost an extremely degenerated eyes where you can see almost all the cornea is degenerated. Where you can see here a spot, and what is this? It is the Bitort's spot. And this picture is to say that this vitamin deficiency has night blindness. So, what is this? It is vitamin A deficiency. Very easy. A 11-year-old child presented to dermatology OPD with the following finding. So, what you can see here, this is the clue. What is it? This is tarred skin. is because of follicular hyperkeratosis. This is otherwise called as phrenoderma. Okay, so which vitamin deficiency can cause this? Vitamin A, not only vitamin A, essential fatty acid deficiency can cause this, and many other vitamin deficiency can also cause follicular hyperkeratosis. Identify the nutrient deficiency from the clinical images. So, you can see rosary here. What is this rosary? It is rachitic rosary. Then you can see the cupping, fraying of the metaphases, widening of the epiphyseal plate. What is this? It is again X-ray finding of rickets, right? And this is what deformity? This is called wind swept deformity. Here you can see valgum, you can see varum. All these deformities you can see in a case of vitamin D deficiency, and it's a child, so it is rickets. Okay, so that is it. Next is again another rosary you can see here at the costochondral junction. But one clue I'll give you here, this is not a non-tender, this is a tender. Plus what you can see is bleeding of gums, hemarthrosis, then anemia which is causing microcytic hypochromic anemia. These are petechial rashes, it is something related to white citrus fruits, and what you can see is the splinter hemorrhages. Okay, so it's a straightforward case of scurvy, which is due to vitamin C deficiency. So most of the metabolic disorders and the nutritional deficiency which you can get as an image based question I have already discussed. Now we'll go to some of the graphs you can get. So number one is you can get, this is a case of familial hypercholesterolemia treated with statins. HMG coenzyme reductase enzyme kinetics is shown here. So you have to tell me what is this enzyme inhibition, where you can see the Vmax is not changing, Vmax dash is equal to Vmax, and what you can see is the Km dash is more than the original Km, and here what you can see is you can see the minus 1 by Km is moving closer to the 0, but at the same time the y-intercept is remaining the same, where you can see an X shape in the Lineweaver-Burk plot. This is called Lineweaver-Burk plot. It's very straightforward. You all know this is competitive inhibition. Okay, we'll go to the next. I'll just show you some other inhibition. So when you can get the Vmax is reduced, and you can see that the x-intercept, this is the y-intercept is moving away from 0, x-intercept remains the same. So here the Km dash is equal to Km. So what is this type of inhibition? It's a non-competitive inhibition. So remember, if you see a V in the Lineweaver-Burk plot, it is a non-competitive inhibition. So if you get two parallel lines, that is what is shown here. If you get two parallel lines in the Lineweaver-Burk plot, it is a case of uncompetitive inhibition. So again, this is competitive inhibition. Competitive inhibition. Okay. So just by one look, you can find the answer. X, it is competitive. V, it is non-competitive. Two parallel lines, it is uncompetitive. That's it. So now this is a comment on the type of the enzyme from the graph. So what you can see here is an S-shaped curve. So it is an allosteric enzyme. If you get an hyperbolic, that is an enzyme which follow Michaelis-Menten kinetics. There is no particular name for it. Almost every enzyme, conventional enzymes are something which follow Michaelis-Menten kinetics. And what is this shape? It is a hyperbolic curve. Okay, so same question if it is asked like which is hemoglobin, which is myoglobin. A question was asked in the exam. So it's not mentioned it's an enzyme, it's a protein. So which is hemoglobin? One is hemoglobin, the other is myoglobin. Which is hemoglobin, which is myoglobin? You all know hemoglobin, oxygen dissociation curve, sigmoid kinetics. So this should be hemoglobin. Myoglobin is not a multi-subunit, so it is not having sigmoid kinetics or cooperative binding. So it is having a hyperbolic curve. So myoglobin should be this and hemoglobin should be the S-shaped curve. Fine. Next is, this is a graph of an enzyme kinetics of an allosteric enzyme, ALA synthase. Modifier A and B is given. So you have to find out which is this modifier. So this is without any effector or modifier. With the modifier A, what you can see is this is allosteric activation. So if it is the S-shaped curve is moving to the left, it means it is activation. If it is moving to the right, it means allosteric inhibition. So you have to find out which is the activator and which is the inhibitor. Always remember, the activator is the substrate. This is the concept that I have told you. And inhibitor is a product. Okay. So what is the product here? For ALA synthase, it is heme. So this is a product. And substrate, this is a starting substrate. Starting substrate is succinyl coenzyme A plus glycine. So definitely it is a substrate. So activator should be a substrate and inhibitor should be a product. So the answer here is D. Okay, so these kind of question also you can get. So this is what? First tell me what is this. You can see blood glucose against the time. What you can see is it is a oral glucose tolerance test. Okay, so this is the renal threshold that is shown here. Find comment on the A. A is, you can see it is at the fasting itself, it is around 250, 1 hour it is peaking, it's every time it is above renal threshold, so urine sugar is also positive, it's never coming down, so this is a GTT of diabetes mellitus. Okay, next is this blue color. You can see that the fasting is normal, 1 hour is also not crossing the renal threshold. Again, it is never crossing the renal threshold at any time, so this is a normal. Okay, what you can see between the normal and the diabetic is impaired glucose tolerance, which is a pre-diabetic condition. So this is again another question that you can get. It is the enzyme reaction coordinate. You can see here. So two arrows are given here. This is arrow A and this is arrow B. You have to tell me what is that arrow A standing for. The arrow A is standing for, this is the free energy of the substrate. It has to reach the transition state. So what is that energy called as? EAT. What is that? Activation energy. Okay, so this is the free energy of the products, and the difference between the free energy of the product and the substrate is delta G, that is Gibbs free energy change. Okay, so this is again a probable question that you can get always, and also remember not only this, what is the shape of the curve? It should go like this and then it comes. This is the shape of a reaction coordinate. So now I'm moving on to some of the molecular biology techniques. By seeing the image, you have to find out what is the molecular biology image. I won't be explaining any of these molecular biology techniques here, but I will just tell you how to identify this molecular biology image by seeing the image. Okay, so what you can see is a foreign DNA, you can see a vector. So what you see here is the recombinant DNA. It is inserted into a bacteria, then it grows. So what is this? It is rDNA technology. So what is this? You can see a allele here, normal allele and a diseased allele. And you can see some of the restriction enzymes are used here, and it is digested with the restriction enzyme. In normal, you can get 2 bands. In a disease, you can get 1 band because one of the restriction sites is abolished here. What is this technique called as? It is called as RFLP. What is RFLP? Restriction fragment length polymorphism. So the length of the restriction fragments is varying. Here we will get 2 fragments. Here we will get only one single or only one long band. So the length is varying here. So it is restriction fragment length polymorphism. Again, what is this? You can see this is a DNA fingerprint that you get from the scene of crime. And we are having 3 suspects here. You have to find out which is the correct suspect. So if some image like this is given, what is this? It is DNA fingerprinting. DNA fingerprinting. So now what you can see is, you can see the genomic DNA being digested by some enzyme. So first what you can see here is it is digested by an enzyme. So this enzyme is a DNase enzyme. Now you will get all the different bands that you get are the product of this DNase enzyme digestion. Now this is the same DNA which is actually having bound, or it's bound with the proteins. Now the bound DNA is also treated with the same enzyme DNase. When you do the electrophoresis, you can see that some fragments are missing. So these fragments correspond to those areas which are bound by this protein. What is this? It is DNA footprinting, and this is to find out the DNA protein interaction. Protein interaction. So if you get an image like this, it is DNA footprinting. Remember, fingerprinting and footprinting are two extremely different techniques. So again, you can see here is Taq polymerase, buffer, PCR tube. So almost everything is given, and three steps is given here: denaturation, annealing, extension. So what is this? This is conventional PCR. Okay. Next is, you can see reverse transcription. Again, you can see PCR. So you can see there is an RNA, a cDNA is created, and this cDNA is later on amplified. So what is this? It is reverse transcriptase PCR, that is to amplify any kinds of RNA. So what is this PCR? Again, this is PCR only, but another type, where you can see a signal. You can see a signal. So when a signal is added to the target DNA, so what is that? It is real time PCR, otherwise qPCR. That Q stands for quantitative PCR. Now what is this? You can see a Cas9 which is coming and binding to a mutated region. It cleaves the DNA, and finally this is being corrected by double strand break repair mechanisms like NHEJ, non-homologous enjoining, or homologous recombination. So what is this? It is CRISPR Cas9. It's a very novel technique, genome editing technique. So it is you should also know, genome editing technique. Okay. So what is this? What you can see here is dideoxynucleotides, where each of these dideoxynucleotides are given a particular fluorescent signal. So from which we are able to find out this DNA sequence. So what is this technique? It is DNA sequencing. And this DNA sequencing technique is Sanger's sequencing. Okay. So what is this technique first? This is an interphase fish. What is the abnormality that you can find here? It is, you can see one chromosome is seen in, not usually what we get is 2. But here we are seeing 3 chromosomes which has the same color, which means this is trisomy. It's an aneuploidy, and this is interphase fish. So if you get round fluorescence, it is interphase fish. One more fish I'll show you. This is not round. You can see the metaphase spread, where you can see all the chromosomes clearly you can see. So this is M fish or metaphase fish. So in this metaphase fish, you can find so many genomic abnormalities. We'll see one by one. Do you find anything here? Yes, there is a deletion of chromosome 1. Okay, do you find anything here? Yes, it is trisomy. Again, I have marked here something. What is this? It is usually what we expect as the color of 8 should be there. But you can see a color of some other chromosome here, like this one. So this color, this is a translocation. Translocation, it is an unbalanced translocation actually. Now another thing that I have marked there is this one. What is this? Again, you can see that one chromosome is missing here, right? It is one chromosome is missing here, where you can see this is a monosomy. Fine. Again, what you can see here, again, this is translocation only. Translocation, where it is 11 and 22. So you can see a color of 11 here. So 11 and 22 translocation. Again, this one, what is the abnormality here? Again, it is translocation, which means this is metaphase fish where you can find so many chromosomal abnormalities. Like that is the structural abnormalities in the chromosome we can detect here, and this is not interphase fish, it is metaphase fish. Metaphase fish, that M not stand for metaphase, that M stand for multicolor. Multicolor fish which is done in metaphase. Okay, so that is about the image based questions. I have tried to cover all the images that you can get in biochemistry, which we have covered under 3 headings. So enzymes and the kinetics graphs and molecular biology techniques, metabolic disorders, and some common tests in biochemistry. All the best to you. Thank you.